I'm actually proud and honored to introduce Dr. Jacqueline from also the Lipedema Institute. She's a physiotherapist with a PhD in oncology from Kamagaro Care Center. She's a coordinator of the lymphedema clinic and also the president of the Institute Onco Expert. She is also the former vice president of the Brazilian Association of Oncology Physiotherapy, right? Yeah. Till 2021. She is also board certified in oncology and women health physiotherapy with specializations in hospital care and ICU, women health, and also author of the physiotherapy in oncology with more than 17 years experience in oncology, lymphology, and research. I can continue also with her CV. She is also traveling around the world, giving her experience and presentations everywhere, recently in our home country, Egypt, as well. So with that, I would like to hand over to you, Dr. Jacqueline. Now you can see. Yeah.
So I would like to thank for the invitation. I'm very honored to be here. And we are going to share our approach here in our institute. And I'm going to talk about physical therapist approach in lipedema. And as we know, lipedema has an important role in inflammation. We have fibrosis and have endothelial injury. So that leads us to insufficient lymph transport. We know that at early stages in lipedema as grade 1, we already have some insufficient lymph transport. And in the latest grades, as the 4th grade, we have also lymphedema associated. So it's very important that we understand this pathological condition, that we know that lymphatic dysfunction leads to more fluid, that leads to fibrosis, that's going to lead to more fatty tissue accumulation. So understanding this, we can understand the importance of physical therapists in the whole play of manage lymphatic dysfunction, manage inflammation, and managing fibrosis. So understanding this, where should we start? We know that physical therapists has a lot of techniques and ways to deal with this. So I should say that in physical therapy, we have 4 main goals, which is mitigate and modulate inflammation. We have to address and stimulate the lymph flow, the lymphatic drainage. We have to improve pain and function, and we have to improve aesthetic aspects. For this, as we are physical therapists, we have a lot of techniques and a lot of devices to help us to do the conservative therapy, for example. We have a lot of data showing that physical complex, the congestive physical therapy works in lipedema. We know that our job, how can I say? Our treatment, yes. We have decreasing pain, we have decreasing capillarity, fragility, we have we reduce volume, we reduce fibrosis, and we enhance the quality of life in our patients. So I think that we all agree that compression therapy, it's one of the big therapy here. It's very important because we know that compression therapy can enhance lymphatic dysfunction and can to manage, can mitigate fibrosis. We know that compression therapy, it modulates inflammation, mitigates fibrosis, and improves lymphatic flow. So compression therapy can be applied as many ways. We can use some bandaging, multi-layer bandaging in late stages of grade 4 lipedema or in post-surgery. We can use compression stockings And we can also use Velcro and wrap devices because we know that sometimes the shape of the legs of lipedema patients does not fit in the size, in the standard size of garments. We also have some technologies that we can use to treat lipedema as well. We know we have, physical therapists has a lot of devices that can mitigate inflammation. So that's one of our goal here. So we can use photobiomodulation, which is the use of low-level laser therapy or LED therapy. We have the use of external shockwave therapy, for example. We can use some like thicker therapy that's like a radio frequency that we use to remodulate the fatty tissue. We can use vibrating platforms in dermology. We can also use ultrasound therapy. We can use manual techniques or instrumental assisted soft tissue manipulation, and we also can use intermittent pneumatic compression pumps. So we have a lot of technology and a lot of techniques that we physiotherapists can use. Here in the institute, we developed a program that's called Lipedema Zero. And it's a 3-phase program, which is personalized for the patient. And we have the phase 1. Our goals is we'd like to modulate inflammation, enhance the lymphatic function, improve the pain. In the phase 2, we can improve aesthetic conditions, modulate fibrosis, and stimulate lipolysis. In the phase 3, we can use some techniques, some devices to treat sag skin and enhance muscle strength. So the Lipedema Zero is a conservative treatment for the patients and also a preparation for the surgery here in our institute. So this is some, I'm showing the use of LED therapy, laser therapy, external shockwave therapy, TECA therapy. Here we have intermittent pneumatic compressions. So we evaluate the patient, we see the needs, and we personalize the treatment for each case. Here I'm just the videos. We do have some great results in the conservative treatment. For this example, we have here a patient with venous insufficiency and lipedema. In the first photo, we have a patient who have a lot of pain, a lot of edema, and some kind of difficulty for walking because of the pain. After the physical complex therapy, the congestive therapy, we can see that the fluid has gone. We can see that the pain is gone. The mobility has increased. So I think that's a very important thing to us to recognize. Sometimes our colleagues in other health professionals has the difficult to separate what is fat and what is fluid. So here I can show you the results of the treatment. We can see that we no longer have fluid, but we do have fatty tissue. Sometimes the people say, no, but I'm still, there's so much edema here. No, there's no more edema. This is fatty tissue. And understanding this, at this time we should address to the plastic surgeon. Right now, I don't have any more fluid. If we don't want the fluffy tissue, maybe we need to get an evaluation for the liposuction, for an example. And here we do have some other conservative treatment responses. We can see that we alleviate the fibrosis tissue, the sag skin, the cellulitis, they call the edema, and we have some improving the aesthetic condition as well. So physical therapy plays an important role in preoperative, conservative treatment, and also in post surgery. So now we are going to show we use some, we have here now our patient using intermittent pneumatic compression, and which is for me, and all here, we all agree that it's an important device that help us to shrink, to have to put out some fluid to get the function, to enhance the lymphatic function. So can we go there?
Yeah. So thanks so much, Dr. Jacqueline. Much appreciated. I can see so many questions already coming. But I will just sure. So as we are also having the expert from Egypt, Dr. Carlos George, who is joining us as well to share his experience. As we said, we are bringing the knowledge from Brazil and from Egypt together because we have so many good examples to share. I can see also in the attendees, Dr. Carlos and others have. So this is really interesting to see their input. So before we go with the patient, can you please, Khaled, show the poll question? While he's showing the poll questions, I can just quickly introduce Dr. George. Dr. George, Carlos George, he's actually a certified lymphedema therapist and the founder of the International Lymphedema Center, ILC. Dr. George brings more than 50 years of intensive experience in lymphedema, lipedema management with a passion for patient-centric and innovation in conversion therapy. He also combines hands-on experience, but also a deep physiological knowledge to advance treatment strategies and outcomes. He has also been speakers in many congresses. As I remember well, he just came back from Tunisia, attending one of the biggest vascular lymphology congress. So now with the question, what is your preferred conversion strategy post-liposuction in lipedema patient? And here this question is actually a multiple choice. A, only bandaging is sufficient, no other conversion needed, or MLD, manual lymphatic drainage. Or B, MLD for a couple of weeks while applying compression. C, flat net compression stocking +2 or 3 after the last MLD session. So the legs are already getting less and you can take the measurement. D, adjustable Velcro wraps or the Compreflex. E, the intermittent pneumatic compression pump device as a daily use as well. So here again, it's a multiple choice and we are talking about the strategy post-liposuction. So you can also mix of your choices. So now I think we have already passed 30, 40 seconds while waiting for the result. Can also Dr. Carlos start with his first questions to Dr. Jacqueline before we start with the patient? Dr. Carlos?
Yes, nice to meet you all. Thank you for the invitation. It's an honor to be with all these professors. I want to say hi to Professor Ahmed Makbaj. Thank you for always trusting us. It's a great honor to be part of your success. Always, Professor Kanto, it's a pleasure to see your results. Your results is magnificent. I can't say how much it's amazing. Dr. Dean, Dr. thank you a lot for your precious information. Dr. Dean, I think we have a lot of questions we can choose. There is a question about what about conversion therapy at the first days of lipedema surgery? Is it recommended or not?
This one question from the audience.
For after the surgery, the first days is recommended to do after the surgery.
Yes.
Hello, hi, Dr. Georgie. I should say that's very important to use and address compression, the postoperative. And I would like to share our protocol here. We use multi-layer bandaging at the first 7 to 15 day postoperative until stop leaking from the fistula. So we use multi-layer bandaging. Also, we apply MLD and compression pneumatic pumps at home. Patients have the pumps in home, so we use MLD pumps and bandaging. After stops leaking, we move to stockings. Here in Brazil, it's not very easy for us to have flat knitted garments. So we use circular stockings. Then we move to knee-high stockings to see if they have to maintain compression or can stop using compression. But we should we prescribe at least to the 3rd month of surgery.
Move forward and have the live case with Dr. Jacqueline. She will check now with her patient. We got the result already from the poll question, and seems we have also people choose all of the options, but there are 80% that choose only bandaging even without MLD. Again, showing how it's really interesting to see how people approach such cases from different parts of the world. But the majority, they also choose the manual lymphatic drainage for a couple of weeks while applying compression, which is matched with exactly what Dr. Jacqueline said. So now to you, Dr. Jacqueline.
The word we talked about.
Is that okay? Yes?
We're here. So come on here, Dr. Victor. There's some... It's working?
Culture starter baseball is like this. Maybe show my spell.
Okay. Here we are demonstrating the use of intermittent pneumatic compression. We use in the postoperative treatment, we use as conservative treatment. I think that this kind of device plays an important role because it's really puts some fluid out. And I think that it's very important to manage and combine this kind of treatment with other treatments that we have in physical therapy. I think this is not the only, it's not a monotherapy, but it's all, we have to use this with sometimes manual techniques, sometimes with another technologies like photobiomodulation or external shockwave therapy, for instance. And also this kind of device, it's important for some patients to have it like home device. Sometimes we have some patients that are not prepared yet, or not going to have surgery yet, and this device plays some important role to manage the edema, the pain, and the function of the patient. So I think that's what I would like to say.
So I'd like to share with you the vascular point of view about this very important device in our practice. So, and take a little of this moment to question Jacques about the needs of having the boots till the waistline or only till the thigh line, and the amount of pressure that a normal lymphatic system can deal without having excessive pressure lesion. What can you tell us about that, Jerry?
Yes. It's very important to know that the pumps should work with the physical and physiological conditions of lymphatic system. So I think that most people think that more that squeeze, better, but that's not true. We know that a healthy condition, healthy lymphatic system supports until like 90 or 95 millimeters of pressure until they how can I say, collapse? How they collapse. So it's important to know that we should not use too much pressure in this device. For lipedema, we can use like do it to 40 or 60 millimeters of mercury. It will depend on the tenderness of the patient. Sometimes they can tolerate more pressure. Sometimes tolerate less. And it's important to know that we have to make sure that our garments have a gradient of pressure. We have to use more pressure here and less pressure here to make sure that fluids goes to the right direction. So it's very important to know that we have to use a very special lymphatic pump for this situation, because lipedema is not an aesthetic condition. We have a disease here. We have some dysfunction of the lymphatics. So the pump should address this part. So it's very important to know that. And here, okay, saying this, in lipedema, we do have our vessels and our lymph nodes here. So we can use the boots or the pants. I do like the pants most because we all do the drainage on the tummy, on the buttocks, in the pelvis. So I think it's more effective to do the drainage on this part here. But we can use the boots or the pants. That's okay in lipedema.
Another thing that I'd like to add is that as a vascular surgeon, I try to think about the best situation where the patient can use the boots previously to the surgery. And it comes to my mind the situations where the patients are so symptomatic that they could not tolerate using compression or stockings regularly on a daily basis. In your opinion, should we think about more situations where we should offer this type of technique to our patients, or would it be like a exception situation?
Well, as the whole world, how can I say, avançando.
Goes forward.
Yeah, goes forward. I think that understanding the use of this kind of devices prior or at home, it's going to be a time saver and a big change in the situation of lipedema. We know that mesmo que eu faça, even we have the surgery, the patient continues to have the disease. So compression therapy is, in my opinion, the main therapy that should be sustained even the patient gets surgery. So I think this kind of device has some hole in this. They can use prior, during, and after, and also at home.
Very good. That's it. I believe that since we are the only mammals standing in 2 feet, probably we will always need something to bring fluid upwards. And since modern man, unfortunately, works sitting in a chair and a desk throughout the day, and we don't move as I think nature intended us to do, devices like this, followed by compression therapy and physical therapist work, are so valuable for our health, not only for our vascular health, that I really think we should discuss a lot more the use of these devices. Thank you. Thank you for that.
Thanks so much, sir. In the Pabico, yours. Thanks so much.
Can you hear me now?
So,
Yes.
Again, thanks so much, Dr. Peter and Dr. Jacqueline, for the very interesting discussion. As we can see, lipedema patient needs really a lot of attention, not only from one side, but we need to have such a great multidisciplinary approach when it comes to the approaching the treatment protocol and follow-up after the surgery. There is very, very nice and interesting comments in the chat that I need to read to you and get your input on that before we move to the take-home message from all the exhibits. So Liliane Milo, I have just returned from a conference on the subject in Germany, where more than 26 countries represent. The statement was that there is no lymphatic involvement. It's not a lymphatic disease. With a new guideline published that goes against the statement of the American guideline, I have been treating patients with lipedema for 23 years, and I feel that even today, the knowledge is scattered and flawed. I would like to know your opinion, and thanks so much. Thanks so much, Liliane, for this comment. We'll take it up and we'll bring it to the end of the discussion with the take-home message. And I don't know if you have any other more questions.
Maybe we have a minute for a question, please.
Yes, of course, Carlos. I will give you the mic now.
Yeah, I was just wanted to ask a question for Professor Kamamoto, if you.
Yep. Okay, so now we can ask the panelists, Dr. Carlos, your questions to all the speakers.
Okay, it was especially Dr. Kamamoto, but of course I will thank all for. I wanted to ask their opinion in cases of advanced stage lipedema with fibrosis. How do you adapt? How we can surgically approach to preserve the lymphatic integrity while still achieve a good volume reduction?
Sorry. Can you repeat again the question, Carlos, please?
I was asking about in cases of advanced stages lipedema with fibrosis. How do you adapt? How he will adapt?
The advanced cases with fibrosis.
Yes.
How with that what?
How you deal with that?
Yeah. How we will preserve lymphatic integrity while still decrease the volume reduction.
So he's asking about the fibrosis.
Yes.
Advanced cases.
Yep.
And also how can we deal with fibrosis
Yep.
in
And at the same time,
without compromising the lymphatic system.
Yep.
Is that true? That the question?
Yes.
Yes.
So we can talk together.
Yes, I think it's important to mention an interesting study that has been conducted here in Instituto Lipedema, where patients were studied, the lymphatic system of the patients was studied through lymphoscintigraphy previous to the surgery and then after the surgery.
Yeah.
And interesting, the majority of the cases, the lymphatic system was
Damaged. That's a point. I do not agree with the statement that it's only a fat disease.
Yes.
It's a whole soft tissue disease. What I mean by that, 60% of our patients, even grade 1 lipedema, has a damaging of the lymphatic system involvement. Yeah. So it's not only fat. It involves half of our patients has vein problems. 60% even in grade 1 patients has lymphatic problems. And that's why we are proposing a multidisciplinary approach, because the physical therapy and the compression, even in grade 1 patients, is essential, because we have the problem of the fluids, even in grade 1 patient.
Yeah.
Don't you agree with that?
Yeah, I do agree. We have some data, we have some scientific studies showing us that we also have backdermal backflow in stage 1 and 2 lipedema. And these studies that we are conducting here show us the same. We have the same results here. So as we know that this fluid can lead to more fibrosis and more adipogenesis, so I think it's very important to address this in compression therapy. And you ask, how do we deal with fibrosis? Here we use, as I said, for fibrosis, we have some devices as photobiomodulation, external shockwave therapy, endermology, some manual techniques, and some instrumental-assisted soft tissue manipulation that decreases fibrosis and also prepare them to the surgery. So in the surgery, Dr. Fabio has to do more, less
Effort, less trauma, in order to remove the fat.
and preserve the lymphatic system.
Yeah.
And just to conclude about the lymphatic topic, in our opinion here is probably halfway, because these patients frequently they don't have the lymphatic tissue diseased from the beginning, but the lymphatic tissue is pressurized by the fat tissue that is
External compression.
yes. So it is going to be a problem unless we treat the disease
In the early stage.
in the early stages. So I think this would be the halfway in this discussion. Yeah. You have opinion about that?
Lymphatic.
Yes, I agree. I agree with you that even on I also agree with Dr. Vito that even with those who never suffered from any lymphatic problem, they found that the compression and the pressure of the lipedema fat can affect the lymphatics, and they suddenly discover that if they do lymphoscintigraphy, they found some decrease in the flow or even some
Backflow.
flow, yes. But this more, of course, with late stages, but can be found also in the early stage. So I agree with Dr. Fabio that we should consider that lipedema is not affected fat only, but it affects all the system of the limb, the vessels and the lymphatics.
Interesting. Good. Dr. Vito, there is also one question from Dr. Haber Aslan. Any idea about the benefits from the lymphato-venous anastomosis for the such type of patient?
Actually, this would be a good choice, a good option of treatment in cases where we have real lymphatic damage, like stages 4 or maybe previous lymphatic damage previous to lipedema. So not for lipedema patients. Do you agree with me, Fabio?
Yeah, I believe so, because in general, what we see is that the anatomy of the lymphatics is too normal in grades 1 or 2.
Yeah.
We have backflow, we have a decrease in the velocity of drainage, but not a interruption into the lymphatic.
That's
so
it.
in stage 4, yes, certainly, it has a role, but not in stage 1, 2.
Great.
Thank you.
Thank you so much. So I think now maybe we can ask this question. Yeah. Yeah, good.